This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to Apple Podcasts and give us a ratings and a review. That way, more people will find out about the Rational Wellness Podcast. And you can go to YouTube and see the video version of this podcast by looking at Weitz Chiro or searching for Rational Wellness Podcast. And if you go to my website, drweitz.com, you'll find detailed show notes and a complete transcript. Our topic for today is mold and chronic illness with Dr. Sandeep Gupta. Exposure to mold and mold toxins, mycotoxins, affects many people and often is an undiagnosed underlying trigger for many other symptoms and conditions. Many people are unwittingly living or working in water-damaged buildings, and this exposure can be causing negative effects on their health, including coughing, wheezing, these are some of the symptoms, respiratory symptoms, shortness of breath, skin rashes, headaches, vertigo, fatigue, memory and other cognitive deficits, abdominal pain, nausea, diarrhea, so those are some of the GI symptoms, joint pain and muscle aches, increased urinary frequency, weight gain, electric shock type pains. There's a bunch of others. Mold or mycotoxin exposure can result in a chronic condition referred to as chronic inflammatory response syndrome. According to an article written by Keith Bernson, MD, who has studied with Dr. Richie Shoemaker, you have to have the following criteria before being diagnosed with chronic inflammatory response syndrome. One, you have the history, signs, and symptoms consistent with biotoxin exposure. Two, you have a genetic predisposition to biotoxin-related illness. Three, you have abnormal visual contrast sensitivity testing. And four, you have positive biomarkers on lab testing consistent with the neuroimmune, vascular, and endocrine abnormalities that characterize chronic inflammatory response syndrome. Dr. Sandeep Gupta is an integrative MD with a practice focus on mold and chronic illness, including the chronic inflammatory response syndrome. Dr. Gupta has physician training certification with Dr. Richie Shoemaker in chronic inflammatory illness, and he has a master's of nutrition with Dr. Gabriel Cousins. Dr. Gupta established the Lotus Institute of Holistic Health in 2017 to provide training in integrative medicine. Dr. Gupta, thank you so much for joining me today.
Thanks for having me, Dr. Weitz.
Excellent. So how did you get interested in studying mold and dealing with patients with mold toxicity?
Yeah, I actually fell into this field more or less by accident. And it really started with a personal experience of water damage to a house, in that my house was flooded. And I think it was around 2012 here in the Sunshine Coast, Australia. And basically our whole bottom floor of the house was inundated with water, and we lost quite a lot of possessions and so on. But more importantly, my partner at the time became very, very unwell, and she was basically lying around most of the day, unable to function at all. Really, I couldn't understand what had happened. I didn't really have a good model for understanding that, so I started researching, as would anyone who wants to help out a partner or family member, and actually a patient came in and finally told me about Richie Shoemaker, and suggested that perhaps I could learn a little bit about Richie Shoemaker and become certified and help a whole bunch of people in Australia. And I thought, well, yes. I mean, why not? I mean, I've got someone who's really, really unwell from what appears to be a water damaged building, and I have nothing else I know, or, I have no one else I know to refer her to, or no other real approaches. So I contacted Dr. Shoemaker, and it took quite a while to connect, actually, to start with, and there was some logistic difficulties and so on. And I ended up having to do the training at around 1 or 2 a.m. in the morning, as I think I was telling you, via Skype once a month. And it was a really steep learning curve, man. It was like, I didn't know what he was talking about to start with. He was throwing acronyms like C4A and TGF beta 1 and MSH and MMP9. And then he sent me a few 1,000-page documents to read. Not 100, 1,000, as far as I remember, like the WHO guidelines and the GAO guidelines, which is the Government Accountability Office guidelines for water damaged buildings. And I mean, my motivation was big enough. And that's the thing, to get into a new area, you need motivation. Otherwise, I guess for most physicians, if you don't have that motivation to learn new and innovative areas, you just stay to what you know, and you just tell everyone, no, there's no problem with mold. But for me, I needed to have a major life situation happen to give me enough motivation to go and really take the time to speak with Dr. Shoemaker, read a whole bunch of documents, and take the time to just make a model for myself in my head. And it was a very difficult learning process, to be honest. I think since then I really tried to simplify the whole thing for my patients and also other practitioners, which is probably something we'll talk about later. But it can be simplified quite a lot. And through that understanding, going through Dr. Shoemaker, I was able to offer a version of his protocol for people in Australia, and many people did find benefit, which was very heartening to see.
That's great. Yeah, it definitely can be quite complicated and difficult to kind of sort through. Hey, Doc, I might want to suggest that maybe if you looked up a little bit, we could see your face a little better.
All right, sure. Yeah, no problem.
Thanks. So when do you suspect that a patient may have an underlying mold problem as part of their health struggles when you're seeing patients in the clinic? What are some of the first things that make you alert to that possibility?
Yeah, so one of the first things actually is just the fact that they've got what we call a multi-system illness. And I think you alluded to that when you were talking about the symptoms, that it wasn't just one body system. So, and I think when you started talking about the symptoms, you first started off with talking about things like cough and sinus congestion and so on. And that's what a lot of people relate to the sort of problem you might get through mold. But that's just really just a very superficial level, you could say, of symptoms, and people who are
thinking, I've got the mold, I've inhaled it, so it's affecting my respiratory system. And
pretty much anyone who's exposed to enough mold will start getting those kind of symptoms. And that's often just due to the colonization of the mold in the body, and even whether or not you're genetically susceptible. However, that's not CIRS. CIRS is when you have a whole host of bodily systems involved. And you mentioned the gut, mentioned energy.
CIRS is the chronic inflammatory response syndrome. This is this chronic sequela.
Oh, yes, thank you. Yes, thank you. That's the acronym. Or even we even go further and call it SIRS, because you get really lazy after a while. And so there's many body systems involved. So if a person comes in and they say, I've just got some bloating and I've got some diarrhea and so on, well, that's not SIRS. That's just one system. But if they say, I've got some bloating and I've got some abdominal pain and diarrhea, but I've also got joint pain and my energy's gone and I'm not sleeping and, I'm getting these funny rashes on my skin.
Right.
Okay, then that's starting to sound more like it. That's multiple systems involved. Now, one of the second things, which Dr. Shoemaker doesn't talk about as much, but it is really important, is the lack of response to nutritional therapies. That's a really important point that I've found through the years. And one simple thing is if basic nutritional medicine and functional medicine has already been instigated and it hasn't been successful, in my view, that's also a very strong point of the fact that there's a lot of inflammation going on. And that's blocking some of the pathways whereby functional medicine protocols would otherwise be useful.
Right. So, for example, a patient comes in with fatigue and maybe you do a nutritional analysis and you find out they're lacking in certain nutrients and you give them some extra nutritional support and they still feel fatigued.
Yeah, that's exactly right. And so that in itself is a pointer towards it. The lack of response of other protocols. And so that's another really important thing. And just the duration of time they've had it is also really important, So, and so with patients who just come in and they're quite new to the world of functional medicine, I will often still try simple things to start with. I go look at their mineral balance, I look at their gut health, I look to see if they have parasites, etc. So this is not the only thing I look at for sure, but the further they are along the functional medicine journey, the more I will start to look at SIRS earlier on and jump straight into that. So if they tell me, look, I've already seen 20 doctors, including 12 functional medicine doctors. I'm on the best possible diet you can ever imagine. It's totally, I haven't eaten sugar for 20 years. I'm not on any grains. I'm on the basic supplements. They pull out their supplement list. These are all the tests I've had. And, you've had patients who come with
oh, sure.
Oh, yeah. The water results that big. Yeah, that's kind of a clinical sign of CRS right there. And, so that means to me they've been through the mill of the standard functional medicine approach. They've already had their gut health improved. They've got their diet on track. Often they've had their mineral balance instigated, and they've treated things like pyroluria if they're there. They've really got their gut biosis working a lot better. Maybe they've looked at their omega-3 and omega-6 balance, and all these things are coming in place, but they're still not well. That's when you start thinking, okay, you've got an inflammatory trigger here. You've got a big biotoxin problem, most likely, that's preventing those biochemical pathways by which functional medicine protocols would usually work to actually be effective. And that's where often in those patients I would jump straight into evaluating them for CRS or SIRS.
Okay, so how do you work up your patients for that? What's the first thing you look at?
Yeah, so the first thing is just symptoms, as we discussed. So is it a multi-symptom illness, or is it more single system? The other really important things is doing an environmental history, and it takes a little bit of practice because, when I first started doing this, I used to ask people, well, do you live in a moldy building? And universally, the answer to that question is, no, of course I don't. What do you think I am? Some kind of, person who doesn't clean their house? It's almost taken as an insult. So I realized one had to be a bit more subtle and start asking about the history of their home and their workplace. Firstly, how old is the building? Has there been a history of water events or tornadoes or anything like that? I guess you'd be asking about in America. We call them cyclones here in Australia, and or flooding events. Has there been a flood in the area? Has there been leaks, either of the roof or of white goods such as a refrigerator or a washing machine? Are they aware of any musty smells or any other type of unusual odors in the house anywhere? And are there any areas of the house where they can see some patchy discoloration on the walls at all? And how about the crawl space? How about the basement? Do they notice they don't feel well when they go into those areas? So there's a bunch of questions like that can give some clues. Of course, that's not definitive, but that can most definitely help. And the other big thing is, how do they feel when they go away from their home from a period of time? And of course, very sick patients may well not be able to leave the house. They may not have done that for some time, but some people do travel. And if they've, for instance, gone away from their home for 5-6 days, they may not have connected the dots, but they may be like, yeah, doc, actually, I felt a lot better when I left my house and I went to that conference in Orlando a couple of weeks ago, right? And so, these are all clues. These are all clues. And so I start with that side of things. There are some more specific symptoms. One of them is more like electric shocks or a vibratory sensation, and other kind of, more neurological symptoms are thought to be more specific for mold toxicity. And so I ask about those. Also, fevers at night is thought to be a somewhat of a specific one. Do they get a lot of thirst, and do they have excessive urination? That's another one that's somewhat specific, not 100%. Okay. So that's the first part, is just the history, as with any evaluation. And
okay. And what's the next step after that?
The next step after that is getting into examination. Okay. And as much as anything, examination is excluding other possibilities. And so I do a nutritional examination. I look at their tongue, I look at their nails, I look at their skin, I look to see if there's obvious inflammatory signs. Now, one really important sign that you do as part of that is ask them to outstretch their arms. And if they have a fine tremor like that might be a sign of elevated TGF-beta1 levels. Okay. So that's a clue. There can be other things that cause it as well. There's something also called dermatographia. If you can see that, for instance, if you have them sit on one of those lattice back chairs, and if they stand up and you can see they've still got the imprint of that chair on their back for some time, that's actually dermatographia. That's a sign of elevated C4A. So there is some little signs like that. The other big thing is looking for, do they have signs of hypermobility? And hypermobility or joint flexibility is part of Ehlers-Danlos syndrome and Ehlers-Danlos spectrum. And often it'll mean that their arm span is longer than their height or the wingspan. And so you can measure that, but also just having a look at how far can they move their thumb back, how far are they able to extend their wrist, and various other joints. And if there's a significant increase in the joint mobility, that would be a strong pointer towards an Ehlers-Danlos spectrum disorder. Some people are not actually that hypermobile, but they've just noticed they've always had sore joints, and they've just got, they're aware that there's a history of Ehlers-Danlos. So that's actually very, very important. There are some other subtle signs you can do, like looking for signs of mast cell activation.
So what does it say if they have Ehlers-Danlos? What does that have to do with it?
Well, that is actually a risk factor, a genetic risk factor.
Okay.
And particularly actually for mast cell activation syndrome, but it seems it is for CIRS as well. So because one of the things that's been described is that their collagen and their connective tissue is less well linked, they tend to release more TGF-beta1. So it's more likely they're going to have a high TGF-beta1, but also it's more likely they'll have mast cell activation syndrome, which is like a sister syndrome to CIRS. And also what we call postural orthostatic tachycardia syndrome, or POTS. So there's a bit of a trifecta where Ehlers-Danlos syndrome, mast cell activation, and POTS. And so, look, it just points you in a certain direction of investigation. And there's also some specific treatments for Ehlers-Danlos for some people are quite useful and effective. So I find that very important to look at.
Yeah, interesting. Increases the risk for SIBO as well.
Right. Yeah, that's right. So there's a whole bunch. Yeah, the SIBO could almost be put in that trifecta. There's a really interesting recent paper actually where a patient with Ehlers-Danlos and had MCAS and POTS and SIBO, and was treated with antibiotics and intravenous immunoglobulin. We call that IVIG. Okay. And low-dose naltrexone. Yeah, the combination of those, and it was reported that they made a complete recovery, which was actually quite difficult in those syndromes. So there is some interesting research going on in that area. So anyway, moving down the CIRS line a little bit further, the next thing is to do what I call the visual contrast sensitivity test, or the VCS test, and you can get one of those kits online from survivingmold.com, and patients can do that test online as well at that website. But in my opinion, it's more accurate if you have one in your office to use that, in person. And And you get an idea, and sometimes you can make some subtle adjustments to the test based on their eyesight and so on. So I do believe it's more accurate overall. If they fail the VCS test, that's quite a strong indicator that CRS may be present. If they don't fail it, it doesn't exclude it. And you need to check, do they have above average eyesight? That's the most common reason that they will still pass. If they still pass the VCS test, but they still have SIRS. And especially if they're quite young and they're in artistic and other professions, and I generally find females tend to have better eyesight in general for some reason, and so that may be a reason that the VCS test is normal, or at least a pass, despite them still having CIRS. And in the cases where it's abnormal, then it becomes a very useful progress marker, because you need to follow it during the treatment and make sure it goes to normal. If it's not abnormal, then it's not as useful as a progress marker. So in some cases it's very useful, in some it's not as useful, unfortunately. So those things I do, and then based on those, you can actually make quite a good assessment of whether they do have SIRS or not. So there's also a symptom cluster questionnaire you can use from Dr. Shoemaker, where you're looking at symptom clusters, and if they have 7 or more, you generally want to evaluate them for CIRS. But really that symptom cluster just goes to just speaks to that idea that it's very multi-system. So you can actually just do that evaluation. So if it's very multi-system and they fail the VCS, you're already looking that it's highly likely that they've got CRS. And I think Dr. Scott McMahon, did a study saying that even with those things, and he also added something called anti-gravity testing, where you actually would push down on the shoulders of the patient and found which arm fatigued first. And if it's the dominant arm that gets fatigued first, that was called a positive test. And he found with the combination of those 3 signs that it was somewhere around 95% accurate for predicting CRS. So even just that part is already very, very useful. The next thing then would usually be to order some lab work. And in Australia, it's not quite as simple as in America, but basically a very simple thing a functional medicine practitioner could do would be to order a nasal swab and see if the patient has a bacteria called MARCoNS, which stands for multiple antibiotic resistant coagulase negative staph. And we send that to Microbiology DX in Massachusetts. And then the thing after that would be then to decide if one wants to do the classic CRS testing.
What about the urine mycotoxin test?
Yeah, so that I was going to get onto that in a moment. Do you mind if I first just cover the blood biomarkers? Yep. The blood biomarkers are the classic way of diagnosing CRS, and as you mentioned, with Dr. Keith Bernstein's essay, those things that he's talking about are the blood tests. They're the blood tests, and so what he's saying when he's saying the typical, blood tests that show the typical neurohormonal changes of CRS, that means there's an increase in the inflammatory markers. So we call them, they're compounds that fuel the fire of inflammation in the body, and that includes C4A, TGF-beta1, and MMP9. Okay, so they're available through Quest and LabCorp, and there's very specific labs for each one that's recommended. There's also another one called C3A, but that's generally only raised in acute bacterial infections, and we haven't found that to be a very useful marker overall. And then there's a number of different tests or hormones which are lowered in CRS, and they're basically compounds which put out the fire of inflammation in the body, but they're too low, so they're it's like your firefighters are not working, and so they include MSH and VIP and ACTH. There's also another one called ADH, or antidiuretic hormone. So that's the typical pattern, is that there's a bunch of compounds which are elevated and there's a bunch of compounds which are lowered. Now,
does anybody have a panel putting all those together?
I think Life Extension have like a panel. Yeah, but they're still only sending to LabCorp.
Okay.
And generally speaking, I don't know anyone who's put the panel of both. The Functional Diagnostic Nutrition Group, or FDN, which I'm a part of, is looking closely at that, at developing a panel for CIRS. And I think they now have developed a panel, which is again mainly through LabCorp, but we also have access to Quest for functional medicine practitioners. So that's the classic
Can
thing.
we just review those really quick one more time?
Yeah, sure. So there's a bunch of markers that get elevated.
Right.
That includes C4A,
Okay.
TGF-beta1,
Okay.
and MMP9.
Okay.
And then there's a bunch of compounds which are lowered, which includes MSH and VIP and ADH.
Okay.
And sorry, one other is ACTH. And so I won't go through which ones exactly order through Quest and which ones through LabCorp, because I think that just becomes too confusing. But the classic things is if you've got the other elements that Dr. Bernstein talked about in his essay, and you have at least 3 or more abnormal markers, then you can make a diagnosis of CIRS. And you start people on the treatment program. Now, to be honest, it's not 100% specific for mold toxicity. I want to make that clear. It really just shows that you have a activation of the innate immune system. And then you do need to do some more detective work. You do need to get to find out if the person does have a water damage building, and you may want them to get an inspection of their building, or at very least have a closer look at it. And in many cases, a very useful thing to do is to ask them to leave the home for 5 or 7 days and do what we call a mold sabbatical. Right. And ideally they go camping. I guess that's probably only amenable to certain areas of the US more than others. And if they can do that and go camping and make sure they're away from any water damage items, they don't want to take, you don't want to get them to take everything from their old house to the tent, because that may be a source of exposure still. That if they feel a lot better during that mold sabbatical, and then their symptoms are reproduced by going back into their home, that's a very strong pointer to the fact that mold toxicity is a big part of this inflammatory response syndrome that they've got. So that's very important.
Do you recommend testing of their home for mold?
Yeah, I do. I mean, the thing is, testing has its pros and cons, and it's not perfect. But the ERMI test, which is a form of PCR testing, is quite sensitive. But again, even with the testing, it's still only a statistical number. You still need to find out, is the person themselves being affected by that amount of mold in their home? And that's why I found the mold sabbatical is very, very useful. And it also becomes the person's personal experience. And there's a couple of psychological factors here that don't get talked about a lot. But one is the fact that if the person can start to feel that they understand their body and how it's responding to mold, I think that gives them a lot of power and feeling of I guess of having control, or having this syndrome in their, they're able to get on top of it, basically. However, if someone gets a test that's very, very high, often that can send them into panic. And the panic, in a sense, and that activation of the limbic system, that's actually part of the whole inflammatory response. So there's some subtle sides of it which taken me a while to get a full understanding of. But one thing is, you not only want to find out that they've got it and treat them, but you want to put them on a pathway whereby they start to de-escalate in terms of the panic associated with it. That there's a sense of calm, and there's a sense of that they know what to do and they can go about doing it. And so it's a bit of a way up, but that I'm moving more and more towards the mold sabbatical as a way of working out how much mold toxicity. There is a bunch of other things, like talking about looking at mast cell activation syndrome, that can actually give the same kinds of elevations and lowerings of those markers that CIRS can. So it's very much a sister syndrome, and the treatment is quite different. And then looking for stealth infections such as Lyme disease and co-infections, Bartonella, Babesia, Mycoplasma, Those things are very, very important. Also looking for parasites of different types, and then looking for viruses and retroviruses is also very important. So there's a whole grouping of causes, not just mold toxicity, but mold is a really important and under-recognized one that's often playing a part to some degree in most people who are chronically unwell and can't get better.
Cool. I've really been enjoying this discussion, but I'd like to pause for a minute to tell you about our sponsor for this podcast. I'm proud that this episode of the Rational Wellness Podcast is sponsored by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help our patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative. This is a great resource for education for practitioners. I'm a subscriber to TAP Integrative. There's videos, there's lots of great information constantly being updated and improved upon by Dr. Lee Salschuler, who runs it. One of the things I really enjoy about TAP Integrative is that it includes a service that provides you with full copies of journal articles, and it's included in the yearly annual fee. And if you use the discount code Weitz, WEITZ, you'll be able to subscribe for only $99 for the year. And now, back to our discussion. And then would the next thing you do would be to order one of these urine mycotoxin tests?
Well, you can consider it for sure. And it's actually something that's just come onto the scene fairly recently. And there's 3 different companies now that are offering it, at least 3. Maybe there's more by the time this podcast gets out. But the original lab was called Real Time Laboratories, and they were using an ELISA test for looking at sub-fractions of the mycotoxins in the urine. And then the second lab that came out is Great Plains Laboratory, and they used a different and more sensitive technology called mass spectrometry, and they seem to have a higher rate of positives, and then now we've got Vibrant Labs who's also doing it, and so in general, I think the test has been found to be somewhat useful by many of the practitioners, although it's not a perfect test, and I want to really emphasize this fact: none of the tests are perfect in CRS, and really there's a lot of clinical acumen that needs to go into it, and nothing really substitutes for just the clinical experience of working with people with the syndrome. And so yes, you can do a urine mycotoxin test. Great Plains is often the lab we recommend. Some people are recommending different forms of provocation, such as using glutathione 500 milligrams twice daily orally for a week beforehand, and or a sauna or hot bath. So you can do that. It still hasn't been well tested. Great Plains themselves are not really recommending that you do the provocation.
Yeah, in fact, they're recommending that you not do that.
Yeah, that's right. So that's one little point of controversy. But I guess that the problem is, that some of the sickest patients will be negative. And so the idea is that if you can provoke them, and, Dr. Nathan, I think, is one of the advocates of that, then it's more likely that, because the problem with the really sick patients is they're not moving their mycotoxins. They're just sitting in the cells causing inflammation. And so that's one of the problems with it, is that a negative result may actually mean that the patient's quite sick from mold and not able to clear it. And maybe we'll find other methods of provocation in future. But the other part of it is that you can't totally exclude a food source to the mycotoxins that are in their urine. And I think it's very important that the person is on a very clean diet, like a mycotoxin-free diet, before you ask for that testing. And then if you see, and a small amount of ochratoxin, maybe up to 8 or 10, is still fairly normal, and I think could be put down to just overall daily exposure from food and general incidental exposure, if you like. But if you find that the levels are a lot higher than that, and you've got a number of other mycotoxins, that may be a pointer towards the presence of mold toxicity, either present or past. Okay. So yes, that definitely is another test that can be done, and it's interesting, but I want to emphasize it's not perfect.
Right. So now what about the treatment?
Yeah. So once you've decided that mold toxicity, so I'm going to sort of separate the two things. The first one being mold exposure and mold toxicity. And when I use that term mold toxicity, what I mean is that firstly, you've identified that they're being exposed to mold, and there's clearly a symptomatic response to mold. Okay. So if they've got mold toxicity and they've got SIRS, then using a modified version of the Shoemaker protocol is still quite useful. And so there's different, basically what Dr. Shoemaker found is that the pharmaceutical binders were the most effective. And I'll track back a moment first before I go on to binders. And the first thing and the most important thing is that they get away from the source of mold exposure.
Right.
That's actually the first thing. And
that's quite difficult for a lot of patients.
Yeah, it is. It is. And that's why, for instance, if you get them to do mold sabbaticals, maybe you can get them to do a number of mold sabbaticals. One thing is it becomes their personal experience. And I think that's really important. Somehow that seems to have a more beneficial effect on the psyche than just seeing, like an ERMI test that's off the chart and a urine mycotoxin test that's off the chart, because I don't know if you've worked with patients who have this. It's just something that's quite confusing and panic inducing for them because they haven't really necessarily personally had the experience that mold's got anything to do with their symptoms, but the tests are saying so. So it creates this huge disparity and panic. While on the other hand, if it becomes their personal experience and they go and do a mold sabbatical, they feel heaps better, they come back and they notice there's a reproduction and they can start to smell. What often happens is their sense of smell starts to improve and they start to smell it all of a sudden. Then you're starting to get, they're starting to get it personally, and it's not so much, they're not so much in panic around it. They can be pretty confident that they're being affected by mold, and simply they understand then what they need to do is get to a place like the place that they went for the mold sabbatical. Now, it may not mean living in a tent, and I think that has some negative psychological effects for most people. But it means getting into a home that's much, much safer. And, in some cases, it may mean using air purifiers, different types of air purifiers for some time as a intermediary step. And maybe even the new home that they get to, if they're not able to have their current home remediated, may need to have air purification running all the time. But the key is you need to basically be in a house that's not fundamentally water damaged.
Right. And now you were about to say something about binders as one of the treatments.
Yeah.
I've heard a number of practitioners recommend doing some sort of liver detoxification and support for bile secretion as a precursor before using binders. What do you think about that concept?
Yeah, I think that's pretty sound because, binders need to bind onto the bile. And if you're not producing much bile, there's nothing for them to bind onto, very simply.
Right. Now, I guess there's different kind of binders, but some of the binders are bile acid binding resins, right?
Yeah, that's right. They're more the pharmaceutical versions. And as I started to say before, Dr. Shoemaker and his research team found them to be the most effective, cholestyramine and colesevelam. And colesevelam was marketed as Welchol in America, but it's actually known by different names around the place. They are generally the most effective, especially if someone is still getting exposed to mold. And the other method that there are multiple other binders, and some people do have bad, troubling side effects from these, particularly if they have mast cell activation syndrome or multiple chemical sensitivity. They may not be able to tolerate hardly any cholestyramine or cholecylamine. It's very important to start with a low dose and build up. And I think Dr. Neil Nathan's kind of introduced that idea to the mold community, and I think it's very valid that start low, build up, and don't go any further than a dose that starts causing significant reactions.
Now, if these strong pharmaceutical binders are creating symptoms, might it make more sense to start with some nutritional ones first?
Yeah, there's no problem with doing that. I generally don't find them very effective if they're still being massively exposed to a water damage building. But yes, there's basically charcoal, bentonite clay, zeolite, and various others that have been trialed. And some people also select the binder based on the urinary mycotoxin test. And generally my approach, and you could say to some degree I tend to get some of the more serious patients, but my approach has been to use the pharmaceutical binders to start with, especially in the first part of their treatment when they're still often being exposed to quite a lot of mycotoxins. And, then once their VCS test has become normal, that was the point in which the old Shoemaker protocol, you would stop using binders totally. I might consider doing a urinary mycotoxin test at that point to see if it appears that they still have a number of different mycotoxins in the system, and then consider having ongoing natural binder treatment.
So what's your typical course of treatment for the binders?
So let's say it's 6 months on Welchol. Welchol is actually my favorite now. I think it's much better.
So will you automatically say we're going to do 6 months and then reassess?
No, I won't say we'll do 6 months. I'll say let's start this and let's see how long it takes your VCS test to get to be normal and for you to be away from a water damage building.
And if they say, is it going to be for a couple of weeks? What do you say?
I say, yeah, welcome to the real world.
Okay.
Wakey. Unless they're not in a water damage building, but that's very few.
Right.
Yeah.
Okay. And then do you support the liver in bile secretions in some way as part of how do you do that?
Well, one thing I do really recommend is the use of coffee enemas.
Okay.
And that's the main way that I use, because basically when you're doing the coffee enema regularly, it causes your gallbladder to squeeze and release bile. It's actually been shown endoscopically that there's an increase of bile secretion, and it appears to increase glutathione, or one of its enzymes, glutathione transferase, very significantly. So I actually find that to be very, very effective, and more effective than actually giving glutathione, in fact.
Do you give glutathione as part of your protocol?
Sometimes, not usually though. Not usually. Okay. It's not a standard part of it. I would say if they do the coffee enemas, I would not give glutathione specifically. I would just get them to do that. And then often if they take the binders just a little before doing a coffee enema, then they're pretty much assured that they're going to have enough bile there for the binders to bind onto. That's a very useful way. I know other methods had been used and utilized. I don't know if you yourself use other methods to get the bile moving.
Yeah, we use herbal bitters, and a lot of times we'll use glutathione and some other liver support, milk thistle.
Right.
Yeah. Sometimes we'll actually do a 2-week liver detox and make sure they're, clean out some of the other toxins that might be in there and make sure their liver detox pathways are working well.
Yeah, I think that's perfectly valid as well.
We'll use phosphatidylcholine as well to support bile flow.
Yeah, I think those things are also useful. I just, they're just not part of my thing. But I do get them to do coffee enemas and liver gallbladder flush, which does include some of those things. And because their liver and gallbladder is often very effective, very affected.
How do you do liver gallbladder flush?
Well, there's a whole protocol, but it basically includes having some herbs for about a month first. And the ones I use are the Premier Research Liver ND and Gallbladder ND. And then get them to have apples on the morning of quite a few green apples, and then they drink Epsom salts, and then they take a big drink of olive oil and citrus.
Okay.
And that gets their gallbladder just have a huge squeeze. But some people who are not well, that can be very aggressive and can make them quite unwell. For others who are strong, it can speed up their progress quite a lot. So I do that from time to time, but it's not so routine. I find just gently using the coffee enemas and doing gentle binders will be more tolerable for the majority of patients.
Now, do you do some sort of gut support? And in particular, some of these binders can be very constipating.
Yes, absolutely. And, one of the things is to start with is just to make sure that they don't have a gut full of parasites or a gut full of mold or fungus or candida. So, and that's really a separate problem to CIRS. So mold colonization is not something that was described in the original model of CIRS, but we certainly have found that some patients can colonize and have a significant fungal infection. And, generally speaking, I use natural antiparasitic agents and natural antifungals to try and clear that. Sometimes, there might be use of some pharmaceutical antifungals. However, I think just trying to support the gut in that way, and then
Will you do that at the same time as having them on the binders?
Oh yeah, you can mix the two for sure. I mean, definitely. But you generally use a low, to start with, as I say, you just go low and start slow. But also things like betaine, HCl, and digestive enzymes and so on can be extremely useful.
Ox bile.
Yeah, all that kind of thing can be extremely useful because people's digestion is often very impaired by the inflammation that's going on. And just, all of the different factors that are going on in their body.
Yeah. And then when do you recommend the use of vasoactive intestinal peptide?
Well, that's towards the end of treatment.
Okay.
And so you generally want to make sure they're out of any exposure to water damage buildings or any significant exposure, I guess. It's very hard to be 100% away from any exposure, and that they've been significantly bound in terms of them, the mycotoxins and other elements of the water damage building. So they've had enough use of binders. VCS test is normal. There's another, thing that we still look at, which is the nasal marcons. Which I mentioned before. Generally, you want to have eradicated that. That's not 100% rule, though. We have found that in some patients, you can't eradicate that easily. And, using VIP early in those patients and coexisting it with or co-prescribing it with the marcon still present hasn't been a major problem in our group of patients, even though that was a caution that was given by Dr. Shoemaker and his group. And then the other thing is I think it's very important to have already addressed the stealth infections. And that includes parasites, that includes fungal infections in the body, and it includes bacterial infections such as borreliosis, Bartonella, Babesia, Mycoplasma, Rickettsia, Ehrlichia. That's another whole vegetable soup or an alphabet soup rather, and and then also viruses and retroviruses are very important to address as well. And that's something that's only quite recently come into my awareness. And so once you've done a lot of that, sometimes ozone therapy can be extremely useful. And Dr. Raj Patel there in California really put me onto that idea that using that, in patients and at that stage of the treatment.
What type of ozone do you like to use?
Well, I just get people to get their own machine and to do their own insufflations, like ear insufflations and nasal insufflations and rectal and so on. And that can be a very useful adjunct, and also using herbal treatments. In a minority of patients, we still do find we have to use antibiotics or antiparasitics or antivirals that are pharmaceutical. But that's not a major.
What's the treatment for the marcons?
Treatment for the marcons is generally just things like silver and EDTA nasal spray. Sometimes using botanical nasal sprays such as the biocidin can be quite useful, and then actually using nasal probiotics after that's done.
Interesting.
So you're treating it more and more like the
probiotics. That's a new one for me.
That's actually been quite successful.
Use for that?
Well, it's a Lactobacillus sakei product.
Okay.
So that's which is the strain that's found in kimchi. So if people want to be really brave, you can put a little bit of kimchi juice in your nose, but I think it burns.
Definitely won't
So
smell like anybody else.
So we've used a product called Lactose Sinus. And you get people,
really?
and that's just like a powder. And you get people to put that on like a cotton bud and just apply that into their nasal passages.
Interesting. Cool.
That doesn't seem to irritate the nasal passages. And so we're treating it more holistically now, thinking of it as a whole nasal microbiome, just as we think of the gut microbiome.
That's great.
So we're not as focused just on one bug. It's more the entirety. So, yeah, I think that's very important. And as I talked about those other stealth infections, if you can eradicate them or at least get them into a state, in which they're not causing major immune dysfunction, that's very, very useful. And then we often instigate a VIP treatment at the end. And one of the things about that is also to try and normalize their neuroquant, just something that I briefly spoke to you about. So in many of these patients, we get them to do a scan called neuroquant. And that's a computerized analysis of a brain MRI. And it looks at a number of different brain regions and compares them to age and sex match controls. And if they've got significant shrinkage or atrophy of the brain, we really want to return that to normal. It's the same thing with that they can have significant areas of swelling or hypertrophy as well. We also want to return those to normal size as part of the treatment. And we believe, and Dale Bredesen agreed with me, that if they've got ongoing shrinkage in their brain, that could actually pose a risk for Alzheimer's disease in future. So that's why in some cases I actually give VIP for several years.
Interesting.
To try and get all those brain areas normal, and it also just helps to de-escalate and the any remaining inflammation that's there.
So this brain this MRI neuroquant, is this something that the average MRI lab will offer, or is only special MRI labs?
Well, it's something that an average MRI lab can offer if they want to, but they have to get connected to Cortex Laboratory in San Diego, and they have to get all the arrangements in place. They need to get the settings, but basically, as far as I understand, almost any MRI machine can be configured to do neuroquant, and they just need to get in touch with Cortex Laboratories and be able to send their images to that laboratory and have it converted to neuroquant and be able to receive the results. And often, Dr. Shoemaker said it's only something like $50 or $60 in addition to a standard brain MRI, so it's not very expensive.
Really? Huh.
So it's in Australia it's usually around $500 for the whole scan, and some people can get some kind of rebate on that, or insurance rebate. So it's quite useful overall. I mean, it's not absolutely essential, but if people can have it done, if they've got a full-blown SIRS, it is very useful, and we want to see that their brain has come back to normal. And part of this also can be looking at brain retraining methods as well. And that can include things like the Gupta program. That's another Gupta, by the way, Ashok Gupta. That's not me. In the UK, who's created a system which I think is very, very useful. And I've been in touch with him personally, and he's that's something that people can find online at guptaprogram.com. And there's another one. There's various other neural retraining systems.
Wow, the Guptas have taken over the world.
Yeah, there was actually something called the Gupta Empire, by the way. Maybe it's coming back. If you read Indian history. Anyway, and then there's DNRS is another system created by Annie Hopper that can be quite useful. There's a whole bunch of other things people can do. I'm very much into people doing psycho-emotional work as part of this. Often the trauma of CIRS has a very significant effect, and it can also bring up past trauma. So I'm a big fan of them doing that kind of work as well. So it's really, we try and take a very holistic approach to.
There's also some protocols that chiropractic neurologists can use as well.
Okay. What are they exactly?
It has to do with eye exercises and other simple exercises that help to retrain the brain. There's a whole program that's been taught. Chiropractors go through this chiropractic neurology program.
Okay, great. So yeah, look, all different practitioners have different tools, and I think just because all of them haven't been studied, that doesn't mean that they haven't been studied in depth with randomized controlled trials. That doesn't mean that they have no value. So I think some of these other methods to help retrain the brain, and this guy Norman Doidge, who has the whole program, he wrote the book The Brain That Heals Itself.
Yes.
Some of those methods can be quite useful. One's also called Firelight, where people put a far infrared device in their nose, and there's a little head. I guess it's almost like a little helmet that delivers far infrared light to the brain. That can be also very useful for healing the brain effects. So a couple of additional little pointers there that can be helpful for getting the brain and back to a more normal state of functioning. That's one of the areas that often takes a little bit longer for people.
Cool. Excellent. So there's been a very interesting discussion, Dr. Gupta. Thank you for sharing with us. How can practitioners get a hold of you and find out about your programs?
Yeah, so the website...
Not just practitioners, patients as well.
Okay, yeah. So patients want to find out about our clinic. The website for our clinic is lotusholisticmedicine.com.au. So that's Lotus Holistic Medicine with no w.com.au. And also check out my online course, which is www.moldillnessmadesimple.com. And that's spelled the American way for any people outside the US, MOLD madesimple.com. And you can also check out my institute at lotusinstitutehh.com. Stands for Holistic Health. And we're doing some online. We're actually doing a face-to-face training here on integrative medicine in general, but really it's about dealing with the complex and toxic patient. That's going to be in Sydney in October. I'm very, very excited about bringing some of the new insights on dealing with these complex patients to some of the practitioners in Australia.
Cool. Excellent. Great. Thank you so much, and I'll talk to you soon, Dr. Gupta.
Thanks for having me, Dr. Weitz.